So that's a very evolving area in myeloma. So right now 3 drugs are standard. We use lenalidomide, bortezomib and dexamethasone. Put together, that's the best combination currently. There's close to 100% response rate. Half of the patients get CR, near CR responses. The reason it's a good question is that because we have since at least 4 new drugs. We have 2 antibodies, we have an HDAC inhibitor, we have another proteasome inhibitor, we have another immunomodulator drug. So then the question comes, what do I give first and how do I go next? And there are various methods and processes one can utilize. Once we start with these 3 drugs, which are right now currently standard of care, depending upon their response and when they relapse, we would go to the next line of treatment. If patients has a slow progression, we can use drugs which are not as aggressive. We can use a cytoxan-like drug to get next line of treatment. On the other hand, if patient has a very fulminant relapse, then we may need to use more of the newer drug together. We might need to use carfilzomib, we might use pomalidomide, and maybe with some of the antibodies. The second part is that some of these newer drugs are now also coming up front. So if 3 drugs are better than 2 drugs, we are now looking at if 4 drugs are better than 3 drugs. So for example, we have an ongoing studies, we and others, to combine this RVD regimen with daratumumab and see if that gets us better, deeper responses. And one of the newer but almost established area in myeloma treatment is to get minimal residual disease, MRD. And if patients are MRD negative, they do much better. That's getting us closer to, one would say, cure. So that's the direction that we are going, using all these drugs to get the deeper response. So sequencing would depend on their response. If they don't get MRD negativity, we're going to do even more for the next line treatment to get them there.